So I have it even worse than Dr. Schneiderman. I'm keeping you from lunch. So we will try to hopefully keep your attention and get through what I have to say. Thank you for inviting us to be present here. I represent the Cooperative Studies Program Epidemiology Center in Durham. And I'm here to talk about a project that we have been the lead on, which is the Gulf War era Cohort and Biorepository project, otherwise known as CSP 585 within VA. Before I go on, I have no disclosures, and what I present is my own views and not that of VA. So the CSP 585's goal was to develop a research cohort of Gulf War era veterans, and when I say that, I specifically am referring to the 1990 to 91 conflict. So this is not post 9/11 veterans; these are of the first Gulf War, as well as a biorepository that would be made available for future research studies. So this study was not designed for us specifically to do analyses, but to create a repository and cohort that others could apply to us for data, for specimens, to answer questions of interest. This was particularly of interest in regards to Gulf War illness, which is not the topic of today, so we'll be talking some about some of the respiratory findings we also have in that cohort. So the current status is that we finished recruitment in May 2016 with 1,275 veterans. We have several manuscripts that have come out already on the just baseline demographics of the population and then specifically looking at women. And we've had numerous requests since it was put into the repository for people wanting data or specimens to do their own analyses. To be eligible to participate in the study, members had to be members of the uniformed service between 1990 and 91. They did not necessarily have to have deployed to that conflict. So we had deployed and non-deployed. They could be users or non-users of the VA. And this is, as you heard earlier, this is not a common thing you see in the VA studies. Most of them are done with VA users. And this is important because it's been well documented that the users of the VA tend to be sicker. They have more comorbidities than those who are not users of the VA. And they had to reside within the United States. So we were recruited across the country. When they consented, they were agreeing to get a survey as well as a blood specimen taken. Then they also consented to sharing of their data and their samples in a de-identified way. Consenting to recontact, there was a plan to do follow-up surveys in the next 3 to 5 years, as well as updating their contact information on a yearly basis. And consenting for recontact for future research studies. We had them do a paper survey that was developed with a committee of Gulf War era study experts, and it was pilot tested. It includes the full Million Veteran Program baseline survey that some of you may be familiar with that project, and covers topics including military service, geographic location if they were in the conflict, environmental exposures, lifestyle behaviors, physical and mental health and symptoms that they might have, as well as medical conditions that they have, and family health history. As much as possible, we used surveys that had been validated to collect this information. They also consented to have us be able to access their medical records, and that includes both VA records, and if they were not being seen in the VA, they gave us a list of their doctors, which they update every year, and gave us permission to access those medical records. Almost everyone provided a blood specimen, and this includes samples for DNA, plasma, and Buffy coat, which are being stored in VA facilities. This gives you an overview of the demographics of the population. Let's see, where's the pointer? There we go. So we had, as I said, about 1,200 individuals. Age was around 54 at the time of the survey completion. Most were male, and racial demographics reflect that of the veteran population as a whole. 70% had deployed to the Gulf, so going back to the sex, so we oversampled for women so that we had a larger sample of women than you would expect for a veteran population. And this is the distribution of service branch. It was about 50-50 between VA users and non-users, with slightly more non-users than users of the VA healthcare system. In terms of respiratory symptoms and conditions, we asked about 3 symptoms and asked if they were present for the past 6 months at the time of the survey, if they'd been having ongoing or continued problems with those symptoms in the last 6 months, and asked about the severity of it. We asked about frequent cough, shortness of breath, and wheezing. Those were the 3 symptoms that were asked about. We also asked about conditions, asthma, and specifically asthma and COPD, if they had them, yes or no, how long they'd had them, and if they were currently being treated for them. And then we asked about exposures. This was also a yes-no question, and then asking about duration of exposure. When we looked at their basic demographics, those did not have any effect on presence of symptoms, respiratory symptoms, with the exception of the fact that those who have a BMI over 30, that was associated with an increased odds of having cough or wheezing. And that's when you're controlling for other demographic factors, including smoking and gender and age, et cetera. VA use was also associated with an increased odds of having those symptoms. The main data that I wanted to point out today was regarding this table here. This is an adjusted relative importance score for respiratory symptoms. So this is looking not only at, this isn't asking just yes, no if they have it, but it includes calculating if they had mild, moderate, or severe symptoms within these categories of symptoms, and then looking at these exposures, how long they were exposed. And so when you're doing the calculation of the overall risk of having certain symptoms, you're not looking just at if they were exposed, but how long they were exposed. As you can see for breathing difficulties, any exposure to chemical or biological warfare agents, the longer the exposure, the increase the odds that they would have those symptoms. Same was true for frequency of cough and wheezing. We also asked about closeness to smoke from oil well fires. And again, the longer they were exposed to those things, the more likely they had breathing difficulties, having a cough, or having wheezing. And when you combine those symptoms together, the combined effect has an odds of 2.4 if you've had 7 or more days of exposure to chemical or biological warfare agents, and an odds of 1.4 if you've been exposed to smoke from oil well fires. Of course, this is all self-report from veterans. This is in 2000. The survey was done in 2010 approximately, from exposures done in the early 90s. Something else that I put on here is serving on a ship, and as you can see, that there is actually a reverse in terms of exposure risks. So people who served on the ship are less likely to have these kinds of symptoms, which is supportive of what you would expect if these exposures are having an effect on their symptoms. And the same was true for some of the other exposures that we looked at, such as location of service or use of certain pesticides, but these are the most significant findings that were found. Next steps include additional analyses to look at how other conditions, including Gulf War illness or neurologic conditions, are affected by demographics or exposures. As I mentioned, we have blood samples, and there's a GWAS that is currently being done, and we'll be using that information along with the survey data that we have. And the samples and the data are in our biorepository, and people can apply to them, and we've had about 12 applications so far who are asking for data or samples to do additional studies. And there's opportunities, as I said, the patients all consented to resurvey, and so there's opportunities to do that to look at further disease progression or ask additional questions. And that's all I have. If you have any questions.
Thank you. Questions for Dr. Wu?
Yeah, I mean, that's impressive, the biorepository especially. Why would you do a GWAS as sort of your first order of business?
So the study was really specifically looking at Gulf War illness, and so there's been interest in looking at, you're saying in regards to GWAS versus looking at mRNA or some of the other metabolites? Yeah. That was just kind of the first step and something that we have funding to. We don't have funding necessarily to do some of those additional analyses that would require applying to the VA for further stuff. GWAS was a part of the initial plan.
You mentioned exposures that were assessed with the yes/no. Could you give an example of some of those exposures, and how do they relate to the ones in this large table? Because these ones are not just yes/no.
So the first question is a yes/no, and then if they write yes, then we ask, well, how long were you exposed to those things? Right.
Can you say something about how the sample was collected, how the sample was of people were identified? I mean, you've got a relatively small sample.
Right. So we
Where did they come from, and what was the catchment area?
the catchment area is anywhere within the continental United States. We started with DMDC records to get names and addresses, and then those had to be updated to make sure we had the right people. But and then it was throughout the country, but starting from a very large population, and we ended up being able to recruit about 12%. That's why the study was initially planned to be much larger, but we had challenges with recruitment, and so it was stopped at the pilot phase.
In the recruitment, was it specifically identified that you were after people who had exposure?
No, it was not.
So you got about 12%.
So I wonder about this issue with disease progression. What markers of disease progression do you have?
So we don't. These are ideas for future research of things that we could look into. So that's not something that we've done yet.
And you got it.
The surveys were done in 2010.
Around 2012, 2014. Yeah.
Is there any issue with recall bias?
Absolutely. Yeah, I mean, it's what we have for this population, but that's definitely something we have to consider as an issue.
So were the reservists accounted for in this study, or because in your initial list you didn't separate reservists, you just had services, National
Yeah,
Guard. And
we do have that information. I'm sorry I didn't have that up there.
and you didn't look at occupational series, occupational codes.
No. I think this is really more than the data that we have specifically. It's a resource for people who have questions that they're interested in looking into, whether it's respiratory or otherwise. That's what it was designed as we collected a very large amount of information on symptoms, conditions, and then have access to medical records that people who have an interest or a question that they're wanting to answer about this cohort, there's data available.
Again, thank you.